appendage course, which I attend every year. I try to at least. As far as background, he did his medical school training and residency at UCLA, correct? And his fellowship was at Stanford, and he did his EP fellowship at UCSF. So without any further ado, Dr. Lee is going to talk about the latest and greatest from 2025 as regards to left atrial appendage closure and atrial fibrillation. Correct? Thank you.
Thank you, Well. This has been a great conference in terms of just overall condensed information of various fields. So I appreciate the other speakers. Also appreciate Dr. Donaldson, for really highlighting some of these salient trials. There is going to be some overlap with what I did. How come it's not moving forward?
Yeah, we had that problem earlier.
I can move it forward.
Hold on, I can do it. I can do it down.
What? Yeah, that's what I'm hitting. Oh, okay, here, maybe I was going the wrong way. I was doing the reverse. Okay, the disclosure I have is I'm one of the medical directors at AgeCare part-time. So I have a dual appointment at AgeCare and at UC San Francisco. However, this presentation really is my own personal views. There's really no conflicts of what I'm going to say. I'm just going to go over quickly, the field of atrial fibrillation. It's going to affect, 1 in 3 of our patients. It's, one of the true epidemics in cardiology.
1 in 3?
Yes. Right. So 1 in 3. But really, we've talked about symptoms, we've talked about strokes, but the other consequences of atrial fibrillation, besides stroke, you have increased risk of heart failure, increased risk of death, and there's data now, increased risk of dementia. All right, so really, that's why you want to treat it. In terms of the pillars for atrial fibrillation, it used to be stroke reduction symptom management, but now it's optimizing all modifiable risk factors. You heard Dr. Donaldson mention the GLP-2 inhibitors. It did not have any effect of increasing efficacy after catheter ablation, but that's after catheter ablation. Really, weight control. I'm a big believer sending patients that are obese or a little overweight, get them to exercise, get them into nutrition, and sometimes I've had a couple of patients, I won't even do an ablation until they, lost significant weight, and that may mean taking a GLP-2 inhibitor. All right. So really, one of the things I wanted to highlight, this is the old previous philosophy. Rate control was as good as rhythm. All right. This is the AFFIRM trial. It's a well outdated study. It's over 20 years old. It was prior to the era of catheter ablation. And more importantly, if you actually look, the drugs they used, amiodarone, aconite, flecainide, propofol, we already know that when you actually combine those in people with coronary artery disease, higher risk. All right, so this basically this non-inferiority aspect was probably attributed to the toxicity of the drugs. So really, this is outdated. And where we're at now, there's been multiple studies. The East AFNet test, basically treat earlier, less cardiovascular mortality, okay? Castle AF, patients with heart failure. You treat them earlier, get them in sinus rhythm, less hospitalizations, less death. So really the guidelines have gone from basically now catheter ablation class 1 indication. And really it's gone from treating earlier to being aggressive. Patients with heart failure, catheter ablation. So Dr. Donaldson, and this is a surgical, and this is one thing, as clinicians, and you guys are general cardiologist practitioners, if you have a patient going to surgery, it's basically all the guidelines say that they should have a concomitant LA exclusion and also a ablation. Right now in the United States, worldwide, only about a third of patients are having this done. So very much an opportunity there. There's technologies that make it simpler. So basically, if you have a patient going to surgery, you should talk to your surgeon and make sure minimally that he's excluding the left atrial appendage, because that's a low risk, opportune time. One thing I wanted to mention, these are all the technologies that Dr. Donaldson covered, in terms of the different energy levels. But one of the things that I wanted to actually mention is not all atrial fibrillation is the same. And really what we're talking about is as you develop, let me see if I can go forward. I'm just gonna skip these. These are the P phase. Is this slide here. Is basically as you progress from paroxysmal to long-standing, basically you develop an atrial myopathy. And it's a chicken and egg effect. What comes first, okay? No one knows, but they are commonly associated. As you progress, you usually have an atrial myopathy. And why is that important? Basically, this is why. You have pathophysiological changes that occur with the atrial myopathy. Structural, substrate-wise, you have fibrosis, vagal infiltration. But more importantly, electrophysiological changes occurs where the inside of the heart is different than the outside of the heart. The inside of the heart after an ablation, you may think that you have total isolation, i.e. this is, this right here, there's simultaneous grids, one on the outside, one on the inside. And you can see here, very little activity, whereas on the outside, a lot of activity, okay? So then the real question, this is a limitation of our technology right now, is that when you do an ablation, you might actually have basically no signals on the inside, but the outside continues. And that's why the recurrence rates, the success rates of catheter ablation for long-standing, persistent with large atria is so poor. And basically, will PFA treat this? This just basically demonstrates that you can ablate the whole back wall, you can ablate the pulmonary veins, and essentially these are two different studies, and I had another one which I did list, that really show no difference in basically treating the atrial fibrillation. The only studies that have actually demonstrated a benefit over PVI alone is when you take this hybrid approach where electrophysiologist works with surgeons and you actually do an ablation on the outside, eliminate the appendage, and also ablate the inside, so-called hybrid therapies. And you can see here, these are 3 randomized trials, that have demonstrated that. And why is that important? Really, in 2025, what are some of the potential ablation trials that were worth mentioning? And it's really focused on more the persistent with large atria and also long-standing. And it was these two. The CSAF, I did mention, that was one of the main randomized trial which showed a difference of hybrid therapy versus catheter arm. But what they presented, and this is, I'm sorry about going backwards, is the 3-year data on this. And you can see even the 3-year data, this efficacy between the hybrid and the catheter ablation arm, significant differences still. So you can see this is a more durable type of procedure. This is surgical, it's a bilateral thoracoscopic, it is more invasive. There are ways to do this now more minimally invasive, via a subxiphoid approach. So I think as you see, it's more the concept that you might need an inside, outside, and elimination of the appendage epicardially. So that's really what these trials are actually demonstrating. Here, AI. Where is AI going to play? Okay, AI is now being wedded to certain mapping systems. And can the mapping system better predict than the human where to ablate? And this was a randomized trial. It was in Nature Medicine, where actually using a software called Volta, the AI was able to guide the electrophysiologist to say, ablate here in addition to the pulmonary veins, okay? So I think it's really this whole concept of really enhancing our understanding. You have the anatomical approach, that was sort of the hybrid. You have this more AI approach. I think what it's going to do, it's going to be the marriage of the two, okay? And here's a simple strategy. Basically, what strategy for which patients from an ablation standpoint. If you have just paroxysmal, or if you have a patient with early persistent normal atria, you would just use, one of the PFA technologies, isolate the veins, maybe the posterior wall. If it's actually more long-standing or persistent with large atria, then I think it's very reasonable in this day and age to try PFA because it's so easy. But your success rates are going to be, in about the 48% range. So if you fail, then you may consider a hybrid approach. All right. So here, this is actually now going to really what all of us were talking about earlier when Dr. Donaldson was talking about, is everyone's concerned about strokes, all right? And realistically, there's only been one study that demonstrates exclusion of the left atrial appendage reduces embolic events. And this is a surgical study called the LAUS-3. And what they did is patients undergoing surgery, they randomized them to having LA excluded, and this is epicardial, not a Watchman, not a Amplatzer. Okay, so this is epicardial. Yeah, it's either AtriClip, either stapling, cut and sew. So it was any of those. So it was epicardial exclusion, and they randomized it to exclusion versus no exclusion. 70% of the patients were still on anticoagulation therapy, okay? But even with those patients on anticoagulation therapy, they basically saw, a 30% increase in, a 30% reduction in embolic events, okay? So this is the first study ever to demonstrate that excluding the appendage works, okay? And this really led to class 1 indications, for every patient, history of AFib, going to surgery, should have their left atrial appendage eliminated. And why is this important is basically, if you look, we talked about, Watchman, Amplatzer, where does that go? Okay, prevalent. I mean, Damien, you've had patients. Okay, if you look at this meta-analysis, and this was by David Holmes, who was really the basically the principal investigator in all of the Watchman trials. He put together this meta-analysis and really highlighted this, the advantage, and remember, this was against warfarin, okay? And it was a non-inferiority study of overall total stroke. And basically, the Watchman device was not, it was non-inferior to warfarin. But look at where the benefit came from, the prevention of hemorrhagic strokes, which is, obvious, right? You take someone off blood thinning medicine, they're gonna have left. But if you look at ischemic stroke, it actually trended higher. So a device is an implant, at least with the Watchman, is not protective from embolic events. And that's a distinction that has sometimes been lost.
Okay. I don't need to interrupt you, but where is DRT factored into that?
No.
Okay.
Okay. Well, DRT may contribute to it.
Yeah.
And actually, this is just the acute, long-term stuff. we haven't even talked about, like what you alluded to, device-related thrombus. In about 10% of any implants, a device-related thrombus occurs. That has been attributed to late strokes. Leaks. It used to be leaks of less than 3 millimeters no one cared about. Now, 5 years later to 10 years later, it's a risk factor for strokes. And now people are doing off-label things to try to close those leaks. And, it leads to complications. But then also, there's still about a 10% chance, even in the best hands, that you still have residual leaks. So then you're basically left with treating patients on blood thinning medicine, and the whole purpose of this thing was to take them off. Right. See, so this is where you have to really have these discussions with patients, where to go. And so right now, guideline therapy, recommendations to do an implant in patients who actually have contraindication to long-term anticoagulation therapy. So that's where the guidelines are, and it's really a 2B, okay? So now this is where we really get into the discussion. Okay, these are the impact studies in 2025 for stroke prevention. And the first two deal with implants, okay? And basically, you do a catheter ablation. Can you take someone off of blood thinning medicines? Those was the impetus of the first two. The Ocean trial, the Alone trial, Dr. Donaldson, actually went through that. And then I'll go through Artesia, which is basically, I'll go through that afterwards. Okay, the Option trial. So basically what they wanted to do is actually test the hypothesis, after an ablation, we commonly put patients on blood thinning medicines. We keep them on it based on the CHADS VAS score, and that's the recommendation, okay? And that's why Dr. Donaldson and I said catheter ablation is not a means to take someone off of blood thinning medicine. So what the objective here is that instead of keeping someone on a blood thinning medicine after 3 months of blood thinning, and you usually do that just because, when you do an ablation, especially in the RF era, you can create microthrombi and that can cause strokes. So you keep them on blood thinning medicines at least 2 months. That's the current guidelines. So after 3 months, the patients underwent a sequential implant of the Watchman device. And then they followed them for basically another 12 months and looked at primary safety endpoint, and then, which was bleeding, and you could see, obviously, again, you take someone off of blood thinning medicines, they're gonna do better. And then also, death, stroke, those, and it was non-inferiority. So you have a superiority safety endpoint of bleeding, not unexpected, and a non-inferiority, of stroke protection. So here, basically, we do implants. We do it very judiciously. We're not a high volume plate because we're pretty conservative. We like oral anticoagulation, but more importantly, we treat atrial fibrillation. Okay, so the reps and things. And a lot of my colleagues, they have gone on the bandwagon that let's just do an ablation and put in a device. Okay, however, there was another study called the Closure AF study, and this was a German study, a randomized trial. Again, sort of similar concept. Can you use a device in lieu of oral anticoagulation, after ablation? But this was actually a higher risk group, of patients, a little bit older, higher CHADS VAS, okay? And basically, bottom line is they found that devices actually had more complications, did not do as well as oral anticoagulation therapy. Okay, now when you have both of these, you have one that's positive, one that's negative, but in a more narrower population of patients, what do you do, okay? And there's arguments that, some people say that this was underpowered, those types of things. Okay, even if it's underpowered, it's hypothesis generating at worst, right? And, you only have one study, on the other side of randomized. So I think you have to use some judgment in terms of, if you have that philosophy, or if your electrophysiologist says, I'm going to do this ablation, but I'm going to put in this Watchman. And you have the right to say, no, I don't think so, okay? Or let's talk about it, and this is where I think it needs to be done. Because Dr. Donaldson already went through the OCEAN trial and also the Alone AF. And remember, okay, so what happens if you have a patient, and both of these studies, the OPTION trial and also the Closure AF trial, those were in relatively more paroxysmal, more early persistent patients. Okay, you look at the OCEAN trial and this, they have a good chance of being in sinus rhythm at a year. Okay, so in that population, and this is how I think about it, is that if you have these, quote, earlier stage atrial fibrillation that do well with catheter ablation, do you really want to commit them to a device, or do you want to wait and see how they do after a year, right? And keep them on blood thinning medicines. See, so I mean, these are all the factors now that are going in. I mean, if you're really thinking about it, responsibly, you should not take one study in isolation. You got to actually look at them, and they're sort of not comparing head to head, but they're at different stages. But then you have to think about, well, catheter ablation, paroxysmal, early persistent, those patients do really well, in terms of nothing. And then to kick it off, okay, and the complexity of your shared decision making is really the atresia study. And this was a study that actually looked at subclinical atrial fibrillation, and subclinical was defined from greater than 6 minutes to less than 24 hours, okay, and basically picked up by monitoring. And they compared aspirin to NOACs, okay? And basically, it was a pig span and aspirin. And they basically demonstrated that, if you do have subclinical atrial fibrillation, apixaban did do better, and and there was basically lower risk of embolic, but the trade-off was higher bleeding. Okay, so it goes hand in hand, right? So I think, but it does raise a question that, it's what Damien said. Sometimes you have these patients low risk and they have an embolic event, right? Now this is some data to say that, well, if you do have it, blood thinning medicine does help. And more importantly, this was the one in 2025 that was just published, or actually,
Lancet Neurology.
Whoops, yeah. Basically, if patients have had prior stroke or TIA, what do you do with those patients? And here again, they demonstrated being on blood thinning medicine, basically should be considered, okay? You do have a little bit of increased bleeding, but definitely lower stroke rates. So, that's why I'm saying this is a complex decision-making process through all of this. The other, it's difficult. And that's why you have to talk with the patient. I think the one thing that these studies demonstrate is you shouldn't slam dunk and put in a device. I think the studies that need to be is really the epicardial approaches, okay? Because that has been shown to be embolic events. And if you can actually decrease embolic events and take you off of blood thinning medicines, that is actually, would be what you want. And those studies have not been done.
But that's kind of what you did on the patient that we did
Yeah.
the
Right. We do AtriClip's Lariat, which is a percutaneous closure device. You know, they both have excellent closure, great safety, but they're off-label use for stroke prevention. You know, and usually reserved for patients that have nickel allergies, failed implants, you know, or have strict contraindication. You know, but those are off-label. But those studies, like what they did in Option, are really what is needed, because you saw in Lao's 3 study, the surgical, they only studied to show decrease in embolic events. Okay, but here's the other, and this is where another is sort of like, you have someone with AF, coronary artery disease, have a stent, all right? What is your antithrombotic regimen? You know, it used to be triple therapy, all right? Then it became, okay, maybe after a month, some people may, for the first month, some people may use triple therapy and then take off aspirin. So the recommendation is really Plavix and your OAC therapy of choice, okay? So what these 2 studies actually looked at is, well, do you actually even need dual therapy? And should we actually go down to, you know, just OAC therapy alone, okay? And, you know, so the ADAPT-AF DSE trial, you know, they basically randomized to NOAC monotherapy versus dual therapy. You know, and the dual therapy is guideline-based NOAC plus clopidogrel, okay? And basically, you know, the primary endpoint was a composite, you know, the general death, heart attack, stenosis, stroke, embolism, and bleeding. So that was, you know, the primary, okay? And you basically look at these and, you know, after 1 year, okay, so the patient was on dual therapy for 1 year, but then afterwards, they randomized it and then followed them again, okay? And basically they found that there was no difference, okay? So it suggests that after a year of dual therapy, you can take them off and you will have decreased bleeding risks, okay? So that was this study. And then this one was another study, you know, basically they were even more aggressive. As you can see their timeline there. You have dual therapy for a month, and then you keep them on it for a year, and then basically the other was basically after a month, you just went to the OAC therapy, okay? And then they followed them, and in this study, they saw no difference in the composite endpoint, you know, deaths, stenosis, embolic events, those types of things, but the bleeding obviously was greater. So again, you know, I think these are 2 studies that are addressing, you know, how do you decrease risk without losing benefit, you know, and, you know, these are 2 randomized studies. So, you know, I'm not a interventionalist, but I do see these patients after the stents are done, and bleeding is real, you know, so I usually talk with my interventionalist and the patient, but I think these 2 do actually give you some direction that it may be reasonable, especially if the Hasbled scores are higher, to maybe go down to just monotherapy for these patients. And then I'm going to end with what are the future impactful studies that are coming up. And I say coming up because the Champion trial is going to be, the results will be at the ACC? Yeah, ACC is next. Yeah.
March, yeah.
Yeah, so it'll be at ACC. Catalyst will be the following year. Laos 4. So those 2 are basically device versus NOACs, okay? You know, a Pixban, Rivaroxaban, you know, because the other ones were against warfarin, and we know that NOACs are better than warfarin. So this is trying to broaden the use of devices. LAOS 4 is sort of like LAOS 3, where they're going to randomize device versus no device. And then you have 2 LEAPS. This one actually has the potential to totally revolutionize how we think. And it's actually a prophylactic. These are patients who are undergoing open heart surgery. Okay, no history of atrial fibrillation, randomized to AtriClip versus no AtriClip. Wow. So it's a prophylactic study of eliminating the left atrial appendage. It's over 6,500 patients. It's completed their enrollment. So we may know the results next year or the year after, because it's event driven. But you can imagine if it actually is positive, patients who are going to surgery, there's no reason, right? And that actually may have huge ramifications on how we treat patients down the road, in terms of OAC therapy, implants, ablation. So, and then the other one is another prophylactic study, and this is, again, patients who are undergoing surgery. Okay, can you do an ablation and exclude the left atrial appendage in patients who have no history of atrial fibrillation but are at high risk, and then actually prevent post-op AF, but then also future clinical? I mean, and you could only do this in the surgical realm. You would never take a patient and do a catheter ablation in someone with no atrial fibrillation. But since they're there, the risk of doing these and the time is minimal. They have a unique opportunity. So these are some of the studies that are actually coming up. So, in summary, just broad general, concepts. Treat AF early. You have a decreased risk of stroke, heart failure, dementia, and death. Okay, PFA is here to stay. It's fast, efficient, but it's not any better than RF or cryotherapy. Consider hybrid therapies for these more advanced stages of atrial fibrillation. The future role of AI to enhance ablation therapy is something to pay attention to, because, AI is this whole thing we're all enamored with, and we have no idea how it's going to impact medicine. And then, it's really, the next bullet point is really the complicated one. You have to make a shared decision making for LAO occlusion versus continuing someone on OAC therapy. And just remember, ablation, if you maintain sinus rhythm, does decrease the risk of stroke. And then the last one is, the earlier stopping of antiplatelet therapy, i.e. clopidogrel, in patients with AF after, adequate time. And what is that time point? You have one at 1 month, one at 12. So at least it gives you some guidelines. So just thank you very much. Like I said, it was sort of just overall, it was complimented Dr. Donaldson's talk. Thanks.
Thank you.
Thank you, Dr. Lee. Why don't you join us here, and we'll opportunity to ask questions and get more insight. So I had a couple questions, as Dr. Sievert always hates it when I stand up there and ask questions. So a couple questions. What about lower dose DOACs? I know there's people with, okay, you do the AFib ablation, then there's this, as you stated and as Dr. Donaldson stated, we should proceed with caution in discussing discontinuation of anticoagulation. So what about the middle ground, maybe lowering the dose, so taking Eliquis 5 milligrams a day instead of twice a day, or is there any role for that, or
no,
or
there are
just don't do it?
There's observational studies, like say with devices that may have had leaks and or thrombus, and you eliminate the device-related thrombus. to actually maintain them on like a Pixaban 2.5 twice a day. There is some of that observational data that is suggestive it's good. But realistically, and I've actually had some patients where they have bleeding problems and you reduce it, the bleeding is no longer a problem. So that's another situation. But if you actually look at the stroke studies, like the Aristotle studies, things like that, or actually it would probably be in the peripheral vascular disease where they use lower doses of OAC therapy. In those studies, they really didn't see much difference in bleeding. I mean, and the comparison of aspirin to a Pixaban, there was no difference in bleeding. So, I mean, that study suggests that, full dose is fine. But really what hasn't been really studied well is full dose versus half dose, So, but it makes sense, but we still don't know, the efficacy and bleeding risk. But probably something is better than nothing.
Yeah, and I think the other factor is the CHADS-VAS score. So if your CHADS-VAS score, I mean, so you've ablated them, they remained in sinus rhythm for 1 year, you've checked on their recorder and they're still in sinus rhythm a year later. Maybe, just look at the CHADS-VAS score before you entertain or even discuss the idea of discontinuing oral anticoagulation.
Oh, yeah.
That would be probably the more responsible thing to do before. You know what I'm saying? If their CHADS-VAS score is 5, you wouldn't even talk about it, right?
Right.
Yeah.
Exactly.
Now go ahead.
Or if they've had a stroke or TIA, that would probably weigh you.
Correct.
Also.
Correct. And again, with Damien's patient that weighs heavily on all of us, I understand, but I mean, an N of 1 does not a study make. I mean, we have to be cautious about, what is the standard of care? Why is it the standard of care? And yes, there's always some outliers, but I mean, in my world, he did the right thing. I mean, this is what the standard of care told us to do, and still it tells us to do that. Now, CHADS-VAS 1 is not, I mean, most people would not necessarily, we give you the option. The option would be there.
Right.
So, now the other question was this whole thing with the prophylactic left atrial appendage AtriClip while doing a CABG is very intriguing to me. And I know you're talking about this as a future trial.
No, it's already been
done because
65 over 6,500 patients were randomized. So for a surgical study, that's huge.
It's amazing.
Yeah.
But now the results have been reported.
No, it has not.
Okay.
They're still collecting. That's why I'm saying future studies.
Yeah.
So this year, next year, sometime.
So we're waiting for that because I kind of already am doing that. So
no, a lot of people are, but
they're going for CABG.
Right, evidence.
Yeah, they're going for open heart, for AVR, or whatever, and they happen to have an appendage. We just clip it, or we just either, clip it or tie it.
What about the unique but not uncommon situation of post-operative atrial fibrillation from CABG, which I've had that scenario arise multiple times where, I've got a guy that's never had AFib or presumably has never had AFib, middle-aged guy, or even 50s, 60s, doesn't matter, goes in, gets CABG, and then has, sort of an incessant post-operative AFib, not just like 2 minutes of it, but, something that we load them with amiodarone, or we have to cardiovert them down the road, or something trickier. And I think post-operative AFib in my world too kind of comes in different flavors. I mean, if it's 18 seconds on telemetry right after they get back to the unit with cardio leads them on and all these other things, that's one thing versus, somebody that's in it for 5 days and it's now complicating their early rehab, and we have to think about maybe we shock them, that kind of stuff. So again, we're putting AtriClips on everybody, I suppose. But it's interesting, if you look at the literature, right, just an AtriClip itself does not effectively remove the obligation to anticoagulate somebody with a chest vascular tube. Is that correct?
Correct. Well, let's actually, you're right. I mean, basically, there's no randomized trials, in terms of guidance, in terms of if you do an AtriClip, can you stop OAC therapy?
Right.
There are observational studies to suggest it, but really there's no proof, as you're saying. The prudent thing, as with LAOS 3, is that you would keep them on because it has an additive effect, right? Okay, I think, the post-op AFib, I did not appreciate it such a big deal. But the surgeons, it's basically, depending on what type of surgery, CABG versus valves, it could be 30 to 40%. And like you said, the majority of that is not an 18-second. It's basically there. You got to treat cardioversion, amiodarone. And that's why the box AF or box no AF trial is, again, it's ones that are at high risk of developing future AF. They're actually doing an ablation plus clip to see if you can prevent post-op AF, but then also clinical AF. So, I mean, those two, the LEAPS and the box no AF, they're sort of provocative studies. I mean,
it's a real struggle for me because I want to do what's ever best for the patient. I'm not super opinionated on it, but it's kind of a weird carve out where we kind of treat postoperative AFib a little different, or we have this sense that it's not quite the same phenomenon.
well, it isn't the same
Right.
as clinical.
Correct.
It isn't. Right.
So, but again, when you see it for a long time, a patient has it. I have this guy who's 55. He has 5 days of post-op AFib. They load him with amiodarone. He goes back to sinus. We put him on some orals for a few months. Wean him off the amiodarone. Now he's back in my office, and he's got an AtriClip. And he's in sinus, and he's not on antiarrhythmics, and life appears to be 100% back to normal. He's revascularized. He's going through his intensive cardiac rehab, running marathons, doing whatever he does, and I have him on Eliquis. And the question is, am I doing the right thing or the wrong thing?
I see what you're saying. Realistically, you sort of do it on Chad's VAS. I mean, post-op AF is not clinical AF, and I usually have the discussion with the patient if they're free of AF for at least 6 months, monitored, self-monitoring. Because anytime I go into a discussion of stopping OAC, I have them self-monitor at least for 6 months just to demonstrate they can do it and that they can tell.
So I put in loops. That's
that's even better.
That's how I've rationalized it.
I would agree.
So it's really nice now with the LINK2s, with the sapphire crystal. You can just pair it up with your cell phone. It's pretty hassle-free for most guys that can. Most of the boomers are pretty cell phone friendly. So that's what I do, so I can sleep at night.
And I think that's it's a similar. No, it is. That's similar, and I think in those patients that never had AF but had post-op AF, they already have their LA managed, whether it's clips, surgical, whatever. I actually do feel comfortable because, like you're monitoring, and if they have AF, then that's a whole different. That's more of a clinical AF. And there's going to be probably 30% of patients. It's just a numbers game. As you get older, you're going to develop AF. So
it may be one of those things where that's just the surgery and the stress of surgery brought a latent AFib that would have revealed itself later anyways, and perhaps you just selected out that category of patients that now have revealed themselves with AFib. Now, would they have probably they would have developed the AFib if you look at their risk factors.
It's close to over 60 too. When you get over 60, then it really becomes ubiquitous, like you said. Then you really can start playing mind games with yourself because now it's that chicken or the egg question. I mean, you could have a guy that has this phenomenon at age 60, and then at age 61 and a half, there's another AFib episode, and the question is, you know, when you weren't looking for it, were there paroxysms?
Exactly, that's the
We also
question you've
have these
identified.
you see these like long interval paroxysmal guys, if you put these new
Yes.
recorders in where, and I've had that, it's really weird. So I'll get patients now, the Apple Watch, I'm sure you're seeing the same thing. It's really opened up a whole new, like, you know, can of worms where people will, they're wearing the watch, it says they have AFib, they come in, you know, we put a patch on for a week or a month and nothing comes back. And then they disappear for 3 months, and then they come back, and they'll bring in, you can print out the Apple Watch tracing.
Yeah.
And it's like, damn, I mean, there's
pretty
irregular R to R intervals, you can see that there's no P waves, it's
Pretty blatant, yeah.
And I'm like, oh, this is weird. You put them on a 12 lead in your office, and they're in sinus. I put loops in those people, and I've actually seen it where they'll go 3-4 months, and then all of a sudden, there's the AFib. It comes back, and they're not having frequent paroxysms.
Yeah, the loops are really, to me, they've become really, really effective, because otherwise you're just missing. Because I've done, you know how you and I have gone through this, where we've put on these patch recordings and they're on for a week and a half, and you don't see anything.
Yeah.
And yet they're acting like they're having AFib.
Yeah. No, I mean, it's the more you monitor, the more you're going to pick up. I think, you know, there's a study ongoing. It's sort of the pill in the pocket approach, you know, where you have these patients very low burden of AFib, but once they get it, they take oral anticoagulation for a month, and then if they don't have AFib, they stop it. So it's sort of, again, you know, you're getting the protection without the long-term bleeding risks. Okay, so that is a study that is ongoing. You know, I probably should have put that in there, because that'll really impact things.
Well, I'm getting hungry. I don't know about you guys.
It's a tricky problem to solve, though, right? Because you have two major failure points, right? I mean, the rhythm control can fail. I mean, it's getting better and better and better, but it can fail. That's a major failure point. And the LAA closure can fail. I mean, you can have leaks, you can have, and so, you know, when you try to combine them, now you have two failure points, and then you throw into that composite endpoints and non-inferiority design on top of it. It's like, I don't know how you ever solve this problem. The question is, are we even asking the right question, or are we chasing the wrong problem, right? I mean, so many people just don't want to take anticoagulation.
No, and I agree. And that's how come I keep going back. I think the trials that really need to be done, I mean, if we're really going down that, is the sort of the option trial, but with an epicardial closure, not an implant.
And when they
Wait,
don't,
I just don't know what an epicardial closure.
Oh, that's
Lariat.
like from the outside.
The lariat.
You know, like
We'll
when the
talk about
surgeons, you know, when the surgeons go in during surgery, the appendage, they'll either cut it or clip it.
Right.
That's epicardial. Nothing's left in the heart. What we're talking
He does it
about,
percutaneously.
yeah, what we're talking about with the devices, all these trials, are with something left in the body, a Watchman or an implanter. And it's, you know, they do a good job at preventing stroke, but there's always this complication of having
This
something
leak.
in
Like he's
there,
talking
a
about,
leak
yeah.
or a device related.
Or-
These are longer term consequences.
But if you close it from the outside,
You
there
don't
is
have-
no
right.
no